Okay, so back to obesity. Normal BMI, again, is 20 to 24.9, okay? If you are technically above 25, you're considered obese. We have different classifications for that, okay? If you have greater than 30 BMI, you're considered truly obese, okay? And then we have like morbid obesity, and I want to say it's like greater than 45 or something like that, okay? All right, different causes. You know, if you eat more than you expend for your energy, you're going to gain weight. Everybody can understand that, right? It has to either be an equal ratio, what you eat, what you put out for sports, for exercise, or you will start stacking on pounds, okay? However, there are some genetic, environmental, as well as hormonal, okay? So cortisol, okay? Insulin, sugar, all of those have a role in our weight gaining ability, okay? All right, a high BMI is a risk factor for heart disease, okay? Because it's high cholesterol, okay? Diabetes, okay? High blood pressure, all of the things, okay? Stroke, heart attack, osteoarthritis. Why? Why would somebody who's obese be at risk for osteoarthritis?
Because they're heavy and the joints can't.
Yes. If you have 400 pounds walking on the same knees that you have, that's a lot of grating and bending and pressure to those joints. And so it erodes the cartilage, okay? All right, increased risk for complications during and after surgery, okay? We have to intubate these people for surgery, and if they're morbidly obese, it's harder to ventilate their lungs, okay? You have this much cushion on top of your lungs, that's going to be very hard for the machine to work against, okay? All right, and then pregnancy and labor and delivery. If you're already 400 pounds and you guys know you're supposed to gain how much during pregnancy? 25 to 35 during pregnancy, but you're already 400 pounds, the doctor's probably going to say you don't need to gain any, okay? Because you're going to put that baby at a lot of risk, okay? Again, definitely type 2 diabetes, okay? If this waist circumference for females, 35 inches, for males, 40 inches, okay, increases that risk, okay? Metabolic syndrome. This is something we call a interrelated symptoms. So it's obesity, insulin resistance. So insulin resistance is we can draw an insulin level on people to see if it's higher in their body. High blood pressure and cholesterol, okay? They used to also put their waist circumference in here, okay? So if you meet a lot of these things, okay, then you can be considered metabolic syndrome, which puts you at risk for diabetes, other things. It's like the leading to it, okay? All right, respiratory dysfunction is one of the most common complications of obesity, okay? True, most of this is because sleep apnea, okay? Yep, and you don't have to be obese to have it, because it can be your tongue, your jaw, things like that, okay? But sleep apnea kills people. They just quit breathing in their sleep, okay? You need to get a CPAP machine then, my friend.
I think I should get my tonsils removed.
Yeah,
I got a really large tonsils.
Yeah, that can be another factor, okay? So how do you evaluate who needs to lose weight? Okay, well, if you're in those BMI ranges and it's risky for your health, then you're going to be educated to lose weight, okay? Modest weight loss, 3 to 5%. Usually we say 1 to 2 pounds per week, okay? Usually this is recommended. I know females, you might do other diets and you might lose more, but 5 to 10% within 6 months is the recommended amount to lose weight, okay? All right. It's more obtainable when you lose it like that. If you lose 20 pounds in 2 weeks, do you think it's going to stay off? No. A lot of that's going to be water weight. It's going to be, you're going to eat a meal and you're going to gain 5 pounds back. Okay? All right. Again, diet and exercise. Okay? Lifestyle and behavior modifications. If someone's a binge eater, they have to learn how to modify that. Okay? If that's psychiatric medications, seeing a counselor, things like that. Okay. Again, dieting, number one thing we do is fewer calories, okay? Your micros and your macros, okay? If someone says they count their macros, it's kind of like Brady is doing. He's looking at his carbs, looking at his proteins, knowing what he needs to stay in per day, okay? Nutritional education. Well, I go to McDonald's every day, but I don't get a soda anymore. Well, maybe you don't need to go to McDonald's every day. Maybe you need to change that $5 where you're putting it. And you can't go to McDonald's for $5 anymore, okay? That's the 1990s, okay? Now it's $15, so you probably can. And then making sure they have the ability and they know what is healthy. Okay, before you guys came in this class, you didn't really know that orange juice is full of sugar and all this other stuff. You have to educate them. Okay? Exercise, okay? A big thing is 150 minutes per week. Okay, so 150 minutes per week. Okay? That can be 3 to 5 separate days, it doesn't matter, but 150 minutes per week, however you want to splice it. Okay? All right, let's see here. Buddy system, extra support, technology. So there's extra little apps now that say, hey, did you get up and walk today? Even your smartwatch says, hey, you need to stand up. Hey, you didn't meet your goal. Hey, you need to go do this, okay? And then there's virtual coaches. You can do exercise classes with people, okay? Let's see, there are prescription medications that can aid in weight loss, okay? All right, so to be able to not apply, but be considered for medications, usually your BMI has to be greater than 30, okay? If your BMI is 27, but you have diabetes, then they might consider doing that, okay? Because it's still a greater benefit, okay? So if you guys, any of you females came to me and were like, Miss Jen, I need to lose weight. Can I get some meds? I'm gonna be like, no, because all of your BMIs are normal, okay? So that is something to think about, okay? Aspect of behavior modification, cognitive restructuring. Cognitive means brain, changing the way we think about food, okay? All right, and preventing relapse. There is something called bariatric surgery, okay? A lot of it now we do the sleeve, which is where we take the stomach. If this is our stomach, okay? And they literally take it and they take this part away. So what you're left is this like banana shaped part of your stomach, okay? If they say add stomach stapling or something, or banding. Banding is where they do it like this, and so you only have the top of the stomach, but that band can sometimes burst, break, whatnot. So usually the sleeve, and they literally take this part away. It doesn't stay in the body.
How do they even do that with like renting your bile from getting?
They suction, so they're just constantly suctioning while they're cutting the top part of the stomach out. Yep. So that is bariatric surgery, okay? Laparoscopic adjustable banding. So that's the band that they literally, it's like a hair tie, but like more technical than that they put at the top of the stomach. So you get full because you only have this much stomach to work with, okay? They can burst, they can pop, okay? Again, they can do it again and again if they need to. They can adjust it. The sleeve, that's what I just drew, okay? I'm not going to go over the Roux-en-Y. We don't do that a lot. And then gastric bypass surgery, that's where they can pretty much take out a very large portion of the stomach, okay? And then you can get something called dumping syndrome, okay? Again, these people are at risk for vitamin deficiencies, okay? Especially B12, because a lot of that can be synthesized in our guts, vitamin D, calcium. So if they do have these surgeries, they're given and they're put on supplements for like their entire life, okay? Roux-en-Y I'm not going to get into, but just know if I do mention Roux-en-Y procedure that it's huge for dumping syndrome because you're taking out you're pretty much bypassing the entire stomach. They just connect the bottom of the esophagus lower, okay? So dumping means like you eat, you poop, like boom, super fast. I know some of y'all might already have that, but like super, super fast, okay? All right, a major complication can be an anastomotic leak. Well, if I take this esophagus and I take out this whole thing, and then I bring it down here and stretch it all the way to my small intestine, sometimes these sutures might break, okay? And then I'm leaking junk into my peritoneal cavity, and then I'm at risk for infection, okay? All right, so after surgery, a lot of times it's full liquids, then puree, then regular diet 5 to 6 weeks. So can you believe that you're on milkshakes or protein shakes for 6 weeks? These patients have to go through psychological counseling before they do this to make sure they understand you cannot eat a huge meal anymore. You cannot eat for 6 weeks except for baby food and a protein shake. Okay? That can be mentally challenging for some people. Okay? Most people keep it off. However, some people can gain it back with those procedures. Okay? It's super sad, but they can. And that's because they didn't get the proper nutrition and dieting advice beforehand. Okay? All right. There are balloons that they can put into the stomach that pretty much just take up space so that you feel full faster. Okay. That's something foreign inside your body, so it's riskier. Okay, for infection. Plenity is a pill that expands the stomach. That's pretty much like fiber. I think literally it's all fiber. Fiber makes you gassy, but it also makes you feel full. So it pretty much is like, it just expands, and so you feel super full. You're supposed to take it like before you eat, and then it starts like expanding. It's like bread and water, and it like, okay, same concept. Okay, space occupying device. Okay. All right, so that was obesity. We're gonna, yes ma'am.
Sorry. How many times can like a person get like a geriatric surgery?
Or a bariatric surgery? I've heard of people redoing that band because they're like, oh, I need to go back and make my band smaller. So that banana-shaped part of the stomach, they'll make it but a lot of doctors don't like to do that because it's here. And it's the habits that need to change. Not that we need to go change this, it's the habits. What are they doing? How are they eating? Because if they're eating smaller amounts, most people don't, and so that your stomach will stretch back. Even though they took a large part of it out, you can still stretch it. Okay? So a lot of doctors, they get mad, and they don't want to do that. So if you had a sleeve, they might be like, well, now I want to ruin Y. And they want to connect, like I said, there to there, which is stupid because anything you drink, you're going to go poop out immediately. And so it does. And then risk for infection, risk for rupturing things. So, because then you have a lot of suture marks, scar tissues, but they can do them. So, but usually they try the new shots and stuff before that. So now we're talking about eating disorders. Okay. I feel like we talked a little bit about anorexia and bulimia. Yes, no, maybe. I feel like, okay. So anorexia, remember, is you feel in your body perception, it's kind of like a body dysmorphia. Okay. You feel like you're fat. You feel, even though you're not, okay, or you have a fear of food, a fear of gaining weight. So it's more of a mental origin, okay? Genetics, family influences, or history of abuse, physical, emotional, sexual, okay? Because this is something that you can control. You can control what you eat. You can control that. So this is actually considered a mental health disorder, okay? Anorexia, okay? All right, so a lot of things can go on. And like it says, precipitating factors, if there's a stressor, death of a family member, being teased, puberty, divorce, things like that can change your mindset. And you need that feeling of being in control, and that's something that you can control, okay? Again, they're usually associated with depression and anxiety, as well as substance abuse and body dysmorphic disorder, okay? Then when they look in the mirror, they truly see like this huge person, okay? And you're telling them like, dude, you're beautiful. This is why boys, if you ever have a girl that does suffer from anorexia, you can say all the words in the world, but it's going to go one ear out the other. They are not going to hear it because to them, they have a true mental disorder, okay? We can treat it with psychotherapy, family counseling, group counseling, and medications, okay? Antidepressants, anti-anxieties. And a lot of these patients it's almost like a day camp that they go to. They can be hospitalized to get their electrolytes back. And I'm talking like really bad, like when their electrolytes are depleted, their potassium's low. And then they go like, I had one patient that she went to an outpatient, very intensive rehab, like every single day for 5 weeks. It was like 8 to 5, Monday through Friday. And it was bad. And I saw her, went from like the word cachectic, which we'll learn, like looks like this, all sunken in, looking like death, to then being like, not chubby, but like a little round cheeks here and there. And I knew that like if I was seeing it, she was seeing it. So you really have to like make sure that they don't go on the other side, because then they can start to do self-harm and other things like that. So she would not look at the scale when she came to the clinic. She would either make us cover it or she refused to get on it. So they are that much like zoned into that, okay? So we already talked about one of these. What is the risk factor? What is a risk factor for eating disorders? What do you guys think? So you can end up with, what is it saying? Increased concern about weight. Other GI problems, okay? I don't like that question. More of a risk factor would be what is the risk factor? The highest risk factor for someone with anorexia is electrolyte depletion. Okay, more so their potassium, because they're not eating. They're refusing to eat, okay? So what do we have to do? We have to normalize an eating pattern, restore their weight, okay? Really work on those perceptions that you are not overweight. But you saying it isn't going to be the end all be all. It's literally extensive therapy that they have to go through, okay? It has to change their way of thinking. You have to slowly get them to start eating more, okay? What electrolyte, do you guys remember, can affect the heart? Do you remember from like week 3 or week 4, we talked about electrolytes? Could be. It's one more that's more important. Say it if you know it. No? Potassium.
Wait.
Okay.
I'll have to be on my mind. It's not potassium. Wait,
Yep.
how-
Potassium.
Potassium.
Potassium, from now on, when you think electrolytes, think potassium equals heart. Okay? Salt equals brain, so sodium equals brain. Okay? Okay? Because salt can make you have seizures, can make you be confused if your sodium is off. Potassium, think heart, okay? If we inject straight potassium into someone, that's what we do in the death penalty. We stop their heart with potassium. So think about it like that, okay? So if they deplete their potassium, too much potassium, too high potassium, you have heart problems, okay? We cause them, okay? So that is the biggest worry, is that they will have a cardiac arrhythmia because of low potassium, okay? All right, again, you don't have to know all this, but during the refeeding stage, okay, correct the eating patterns such as the irregular eating, vegetarian, restricted food, whatnot, okay? This can, during this time, if they're going from like strict no eating to then us putting all this food in them, we are going to have a lot of electrolyte shifts in and out of the bloodstream, and that can also cause these electrolytes to shift and can cause this refeeding syndrome, which can be life-threatening. Okay. All right. Let's see here. Still working on anorexia. Okay. So awards, positive and negative feedback, all of that stuff. Okay. So that's anorexia. We got it. Okay. Bulimia. Okay. Bulimia nervosa, also categorized as a mental health disorder. Okay. It is an eating disorder, but it is a mental health disorder. Okay. Still has increased. What is it saying here? Mortality rate is less than that associated with anorexia. Okay. So because with bulimia, they're actually eating, but they're binging and purging. Okay. They don't necessarily have to binge and purge. They can just go out to lunch with you, then go to the bathroom and throw up everything that they ate. Okay. Or they use laxatives to go poop. So to like get whatever extra body weight they can off. Okay. So it's recurrent episodes. They could eat, like I said, they could go home and eat a whole apple pie and then go to the bathroom and throw it up. Okay. But it could just be their normal food that they're eating. Okay. So these patients are going to have dental decay because why? They're throwing up all the time, and continued acid on those teeth. Okay. You might see that their hands are going to have scabs or bite marks, or because you're gagging yourself to throw up, okay? And so you might see that on their fingers or hands, okay? Again, this used to be called compulsive overeating, so now we're going just to the binge eating, okay? So that's pretty much bulimia. Bulimia doesn't have as much of the electrolyte abnormality. It can, but not as risky as anorexia, because anorexia, you're pretty much like limiting everything. Okay, you might drink some water today and that's it. Okay, whereas bulimia, you eat but you throw it up, so you're getting some of those nutrients. Okay, binge eating is eating really quick until you're uncomfortably full. This is what all of us are going to do next Thursday. Okay, but we don't do that every day. Okay. This can also come with other disorders such as anxiety, depression, OCD. Okay. So binge eating does not involve purging. This is a lot of the times, if anybody's watched the 600-Pound Life or anything like that, this is the problem that they have. It's their binge eating. Okay, they sit there and eat 4 tubs of ice cream or 6 pizzas. Like, that's not a normal behavior. Okay. And then, this is a big thing to remember. I'm not sure if it's a test question or not, but they feel disgusted with themselves after they do it. Very depressed, very guilty. Some people also become cutters because they're mad that they just did that behavior, but they don't know how to control the behavior. Okay, so then they do self-inflicted injury. Okay, again, we already said the depression, the anxiety, alcoholism, because they get mad and depressed at themselves, and it's just like this vicious cycle. Okay, so again, it also needs mental health therapy, okay, counseling, medications. Okay, they need that cognitive behavioral to change their way of thinking. That it is not normal to sit down and eat 6 pizzas. It's not normal to go through McDonald's drive-through and order 15 Big Macs for yourself, like that type of thing. Okay, and then they need to be in some type of weight control program afterwards. Okay, so that's it for we're not going to get into that. So anorexia, bulimia, and then binge eating. Make sure you kind of know the differences between those. Okay, binge eaters do not purge. Bulimia purges. That means they throw up. Okay, anorexia typically doesn't do that. They're going to just limit their intake. Thus, they're at higher risk for electrolyte imbalance. Okay, and they're all considered mental health disorders. Okay, all right, we're gonna move on. This is nutrition for clients with critical illnesses. I'm going to pretty much go pretty fast through this and pick out the important information here, okay? All right, because you'll go over this more in depth in all of your nursing intensive classes, okay? So anytime you're in the hospital, it's considered a period of stress, okay? Physical, emotional, and just to your body. That is stressing your body. It's out of the norm, okay? Anytime you guys do a sport, play a game, that's putting stress on your body. It's increasing your heart rate, increasing your blood pressure, okay? Your metabolism and nutrient needs are higher, okay? Let's see here. Rise of glucagon with your catecholamines. Do we talk about the fight or flight here? Fight or flight? No? Yes, no? Okay. So when you do that, your catecholamines increase, okay? Your catecholamines are dopamine, norepinephrine, epinephrine, okay? When your body feels that surge, it's like, oh crap, something's chasing me, I gotta go. Well, then your body and your liver pumps out glucagon, which is sugar, so then you have that circulating volume of sugar, okay? If you're running from a tiger, you're gonna need it, okay? All right, hormonal response to stress. Well, let's just keep going here. Catabolic and anabolic. Do you guys know the difference between that? Okay. Let's see if we have a. Yes or no for the catabolic and anabolic? Yes, no? Do you remember it from anatomy? Okay. Probably remember the word, but that's it?
Yeah.
Okay. Let's see the simplest form to do it. Okay. All right, so catabolism, okay, is breaking down something, okay, breaking down something. So think C for crush, okay, you're breaking it down, okay. Anabolism, an anabolic steroid does what to people, Brady?
Anabolic steroid?
Mm-hmm. An anabolic steroid does what? Athletes take them all the time. What happens to their bodies when they take them? They get bigger. Okay, so they're so it gets bigger. Okay, so you're building. So think A for a symbol build. Okay, building muscle, tissue repair. Okay. All right. All right. Fight or flight response. Okay, that's when, like I said, we already kind of talked about that. Let's keep on going. Anabolic. Okay. positive nitrogen balance, I'm not gonna really, quiz you on all of that, okay? Let's see here. Let's see if I can pull up the flyer. So if we're breaking stuff down in the catabolism state, we're trying to get those nutrients for our fight or flight stage, okay? If we're in the building stage, okay, we're repairing, we're storing, that's more of what we call our parasympathetic nervous system, our rest and digest stage, okay? All right, inflammatory response. Let's see how much we need to get in here. Nah. Nah. This is like your first week of patho, so I'm not gonna worry about that. All right, SIRS is a systemic inflammatory response system. It's a life-threatening condition. We saw a lot of this during COVID. Okay, it could be like the flu, COVID, whatever, but it involves this whole body response, and the patient becomes septic. Septic is a systemic infection, so bloodstream infection. Okay, life-threatening. Okay. Impaired blood pressure, low blood flow to all of your extremities, shock, and death, okay? So obviously we need nutritional support when that happens, okay? These patients, just like we talked about, are either gonna need parenteral or enteral nutrition, okay? Because they're not eating, they're not drinking, they're on the ventilator, okay? All right, we're not gonna calculate all of that. Again, underfeeding during critical illness, 80% of calories is associated with shorter intensive care units. These patients don't need to be fed to their, like they're walking around. They're not doing anything, okay? Their blood is being shunted to their respiratory tract and their brain to just stay alive. So they don't need 2,000 calories per day. So we will give them a lot less than that, because all that they need is like literally their basal metabolic rate. They're just laying there. They're just surviving. Okay. All right. You don't need to know hypocaloric is maintained for 3 to 5 days. You don't have to know that. But I would like you to know that the protein needs, okay, 1.2 to 2.5, just know that they need protein to heal, and especially in burn patients. You're building new skin, for God's sakes, okay? Burns, wounds, any of that, if you see that question ever, it's going to be protein, okay? You need more protein, okay? Arginine, glutamine, those are some of the non-essential amino acids, okay? I'm not going to ask you that. All right, again, carbs and fats, micronutrients, the vitamins, okay? Like it says, it's unclear, okay? But we try to put the vitamins in the parenteral, it's already in there, and in the enteral, okay? Which we already talked about that. That's your YouTube from last week, okay? Parenteral nutrition, okay? Associated with increased rate of hyperglycemia. What does that mean? High blood sugar. High blood sugar, okay? All right, and remember enteral, okay, is recommended over parenteral, because if I'm putting parenteral right into the IV and it's literally a white, fatty, thick fluid, that's at risk for infection. It's got sugar, it's got fat, and it's going into my vein, okay? It can light up the vein, make it irritated, and then if it blows the vein, then you're putting fat and sugar into their just tissue, okay? Which is not safe. So we want to do it either NG tube or G tube if possible, okay? All right. Last up to 2 days. Okay, so burns. You think burns, think protein, okay? They also need a lot of fluids. Like, y'all have to calculate the amount of fluids in your pharmacology and adult 2 class. It's like so many liters of fluids they need for burns, because you're losing that. Remember, like, think about sweating. Well, when your skin, you know how wounds like ooze? If you're burned all over, you're oozing so much. So you're losing so much volume.
I was gonna ask that. I burned my finger cooking pizza, and then like bubbling, and then like the clear bubble, like clear liquid. Clear liquid. Is that not just water? Is it?
It's inflammatory markers like white blood cells, everything going to that site to try to to try to heal your body. It's made of white blood cells and other inflammatory markers. Okay. All right, vitamin C and zinc is also good for wound healing. Let's just keep on rolling through this. Okay, that's it for that. All right, we already did that one. 19. This is upper GI. I'm going to review it because it's next week for you guys, but you're already here, so I'm just going to run through it, okay? We already talked about anorexia. We don't have to talk about that again. All right, so nausea and vomiting. Everybody's experienced nausea and vomiting, okay? Whether it's viral or bacterial, okay? It can be related to multiple different things, okay? Multiple different issues, medications, side effects, whatnot, okay? This can cause electrolyte imbalance, okay? All right. Usually you are not going to feed somebody when they're nauseated because they're going to throw up, okay? So you need to give them like ice chips, clear liquids, popsicles, things, and then small foods, okay? This is why we say the crackers, we say the toast, okay? Because that is digested in the small intestine, okay? All right, let's see what else. Mouthwash, limit a ton of liquids. If you're starting to feed them, you don't want to be like, hey, drink this whole orange juice and like you're going to get sick again, okay? Avoid high fat or spicy foods. You guys, that's kind of like self-explanatory. You shouldn't go to Taco Bell if you're feeling nauseous, okay? It's just too much, okay? Dysphagia, okay, or dysphagia with a G is trouble swallowing, okay? You can get obstructions in the throat here. This could also happen for all of these diagnoses, okay? You don't have to know all those, but I would know the definition of this word, and it means what? Difficulty swallowing, okay? All right, again, these patients will get thickened, okay? They will get their liquids thickened. I think I talked about that in another class. It's literally like a powder you put on their stuff, and you're giving them water on a spoon that looks like Jell-O. Because if it's just too liquidy, they couldn't drink a regular drink because they would choke on it. Okay, so it has to be thicker for it to swallow appropriately. Okay. So a question could be like, how do you deal with a patient with dysphagia? Make sure they have thickened foods. Cut their food small, things like that. Don't give them straight liquid drinks. Okay. It might look like baby food on your meal tray, like in the nursing home. If you've ever seen that, that's why. Okay. All right, GERD. GERD is gastric reflux. Okay. This is usually because the lower esophageal sphincter here is a little floppy. Okay. So there's a sphincter right here. And like we've already said, there's acid in here, right, in our stomach. If this is a floppy little sphincter and it doesn't like to close all the way, you can get reflux. That's where it gets its name, of acid into the esophagus, okay? Also, wearing tight clothes, super high, bending over after eating, or lying straight down, okay? Because then that esophageal sphincter can still be really floppy and it's gonna backflow. So teaching patients could be sit in a chair, go for a walk after you eat. So the food follows gravity, okay? Makes it down in the stomach. All of those things. There are medications that treat the acid, okay? And then surgical intervention if needed to help fix the esophageal sphincter or whatever the problem is, okay? There's a lot of foods that make GERD worse, meaning makes the reflux worse because it can increase the stomach acid. Pretty much name anything you love, it's going to cause it, okay? Caffeine, chocolate, orange juice, any citrus juice, all of those things make it worse. Bananas, oatmeal, like even weird stuff you wouldn't think can make the acid worse. Okay, alcohol, spicy food, okay, all those things, okay. I would know a couple of them, but just remember, girls, it's all the things that we love. So, okay, peptic ulcer disease. These are ulcers that are in the stomach or in the small intestine. Okay, ulcers is like an erosion. Okay, so you get like a little spot that starts. Okay, being eroded. It could be there, it could be here, okay? And if it erodes too far, it can perforate the wall and literally have a hole through the stomach, okay? Again, this burning stomach pain, worse at night or when the stomach's empty. Why? Because what happens when the stomach's empty and there's nothing there to cushion that ulcer? There's just acid on that ulcer. Okay, not very comfortable. Okay. All right. Anti-inflammatory drugs, ibuprofen, aspirin. Okay. All of those are very high risk to cause stomach ulcers. Okay. So if you eat ibuprofen, you need to eat it with food. Okay. So it kind of gives that extra coating to the stomach. Okay. Peptic ulcer disease increases your risk for GI bleeding, which can be life-threatening, okay? Because that ulcer can get larger, and then it starts to bleed because you're eroding literally into the stomach lining. If you keep eroding, there's blood vessels in there, okay? These people can die from this, okay? Because it can bleed. They vomit blood, all those things, okay? Iron deficiency anemia can develop because of blood loss, okay? All right, peptic ulcer disease again. We got to tell them to avoid all those things again, okay? Probiotics can be helpful. There is a bacteria called H. pylori that they will test a lot of these patients for because the H. pylori bug literally likes to clamp on to the stomach lining and it starts the erosion as well, okay? So, and then smoking and alcohol can contribute to the ulcers. Okay. All right. Avoid eating 2 hours before bed. Okay. Gastroparesis. Paresis. What do you guys think that means? Paresis. Any thoughts?
You said gastro.
So gastro means stomach. Paresis. Okay. Okay. So paralysis means like loss of function. You can't move, right? Paresis means very slow, okay, slower. So it means the stomach and the gut is very slow, okay? Very slow, okay? This is commonly seen in diabetes, okay? Because they kill the nerves to their stomach and their intestines. So their food is staying in there a lot longer, okay? And it can also happen for other surgery reasons and things like that, okay?
Does it stay in the stomach a lot longer, or like the entire digestive system?
All of it.
So, when it like huge complications, that'd be like constipation because of
100%. And the semaglutide that's all over the internet and people want to do, it literally induces gastroparesis. So people get put in the hospital for bowel obstructions, which is the worst case scenario of constipation, when your bowel literally has a ball of crap that can't be moved, okay? And it can be surgery, NG tube, things like that, okay? What do they need to do? Well, smaller, more frequent meals, and then we give them a lot of medications that help promote that peristalsis, okay, of the intestine, okay? Sit upright after eating. Avoid alcohol and smoking because those will damage the nerves even worse, okay, and the blood vessels. Consume more liquids, okay? Dumping syndrome, I kind of already talked to you guys about that. If you have your stomach removed or anything like that, it's just the contents go straight through you, okay? And then you poop really like super fast. Have you guys seen the girl on TikTok that has like a colostomy bag? She literally like drinks her drink and it's literally coming out like before she's done with her drink out the colostomy. That's literally an example of dumping syndrome. It's literally like coming out the bag as she's still drinking it. That's how fast it went through the intestines. It was wild.
So is it possible to gain weight with that or no?
Not really hard. So they have to have supplements. They have to have high calorie supplements because you could literally get nutrient depleted. And they probably give her meds to slow it down and all this kind of stuff. You would want to, for dumping syndrome, you want to induce a gastroparesis. Makes sense? Okay.
Would that make them eat more because like it's already out of the system quicker? Or?
Yeah, they're probably hungry a lot more, and they're probably never satisfied because it's just going so fast. So people that might have that, it could be like stomach cancer, and we removed their stomach and we connected, the esophagus to the small intestine, and it's just straight through. Okay, super bad. Yeah. 10 to 20 minutes of eating. Okay, it could also lead to vomiting and diarrhea. Okay. Let's see. Gastroparesis. Sometimes they might have that, hopefully, so they can get some nutrient. Okay. Hypoglycemia, shakiness, sweating, confusion. Okay. Obviously, maldigestion, malabsorption, like we just said, because they need calorie-dense foods. Okay. Small, frequent meals, protein and fat at each meal. Okay. And then don't drink your liquids with your food, if possible. Okay. All right. This is super long, so I don't know if I don't know if your brains are going to be able to handle this right now. So I'm literally just this is what I call like speed reading. I'm literally just going to pull out bullet points that you need to either write down or highlight, okay? You guys can read this next week. I just want you to know what I feel is important from it, okay? So this is lower GI tract. So we're talking about colon and so forth, okay? And accessory organs. So that's probably like pancreas, gallbladder, liver, okay? So there's probably a lot of content in here, okay? Okay, this is just saying that most of our nutrition occurs in the first half of the jejunum, which is in the small intestine, okay? Accessory organs, all the ones we just mentioned, okay? All right, constipation. There is a true definition for constipation. Usually it's less than like 3 bowel movements in 5 days. I'm not gonna make you pick that out, okay? But just know that it's hard stools that are hard to pass, excessive straining, okay? What's one easy way you can prevent constipation? Anybody know? Eat fiber and drink water. Okay. We don't want to take laxatives if we can help it, okay? So fiber and water, definitely need to know that, okay? Diarrhea, people might go poop once and have liquid diarrhea and say they have diarrhea. That's not true. Diarrhea is technically like 3 to 5 bowel movements in a 5-hour period or something like that. So it's multiple bowel movements that are liquid to say you have diarrhea. Okay, if you had one liquid bowel movement, and that's what you have. You had one liquid bowel movement. You do not have diarrhea. It's not. You have to have multiple events to classify it as diarrhea. Okay. All right. This can also cause malnutrition because it's going through so fast, so we're not getting our nutrition that we need absorbed. You can get antibiotic-related diarrhea. It's very common. That's why we tell you to eat yogurt and take a probiotic. C. diff is very severe. It's where overgrowth of C. diff, which we normally have in our gut, but it's overgrowth of the bacteria. It can cause 10 to 15 times per day. It smells horrible. When you smell it as a nurse one day, you're going to know what it is. You got to go in contact isolation, gown, gloves, all that stuff. It's not good. Okay. You learn about more diarrhea in all your other classes, how to treat it, all those things. Okay. Okay, lactose intolerance, that's a milk product, okay? That can cause abdominal pain, diarrhea, so then they need to avoid milk products, okay? I think celiac is in here somewhere, so IBD, okay? You learn about this a lot more in patho and adult one and everything else, but Crohn's disease, ulcerative colitis, okay? They're chronic inflammatory autoimmune disorders, okay? Usually associated with bloody diarrhea, okay? Let me see here. They do ask them to get on specific diets. Okay, celiac disease. Please know celiac disease. Anybody know it? All right. Celiac disease, they cannot eat gluten. Does anybody know what gluten is in? Yes. Okay. No gluten. Gluten. This is a acronym that you guys can remember. Barley.
Oh, we get that.
See? Good. Good, good. Rye. Oats. Wheat. Equals not good for celiac. Okay? So remember brown for celiac disease. Okay? They cannot eat these things. Okay?
I got a buddy that has this. He's lost like 40 pounds
Yeah.
because of this.
Yep, and
you see like one of the bigger kids.
Yeah.
Like he wasn't fat. He was
You have to learn how to
Now
change
he's
your diet. Mm-hmm.
Now he's like 150 pounds.
Yeah. Are they going to die if they eat these things? No, but it's going to make their life miserable. Diarrhea, bloating, abdominal pain, cramping. Okay? And then they don't really, their body's not really able to absorb the content anyway, so it's kind of like a waste of time for them to eat that stuff. Okay? All right. I'm not going to go over all of it, but that's the biggest part of it. People can have, so it's also like an autoimmune thing, so they can do blood testing to see if they have the factors for it. Okay? Short bowel syndrome, pretty much kind of like a dumping syndrome. Okay? Irritable bowel syndrome, everybody's probably had a time in their life where they had irritable bowel, where they're like anxious or whatever. There can be a mental aspect of this. With anxiety, it can cause diarrhea, okay? Also causes bloating, diarrhea, constipation. It can be a mixing of both. So IBS is usually a mixture of diarrhea and constipation with bloating and that. Gotta go right now, okay? Caffeine, avoiding caffeine, because caffeine can increase peristalsis. If you increase peristalsis, what are you going to do? What are your bowel movements going to be?
What?
If you increase peristalsis in the gut,
Well,
Yeah.
fat.
the fast. Anybody ever drink coffee and like, I gotta poop. Let me go to the bathroom. Okay. No.
I don't get caught that much.
Well, there you go. All right, let's see. Diverticular disease. Okay, so diverticulitis and diverticulosis. Okay. If the American diet was not poor, we probably wouldn't have this. But in the colon, so remember, we have this up, down, lower, poop chute. Okay. Okay. So here is your large intestine. Okay. Very poor drawing of it. But you get pockets. They're called diverticulum. Okay. They're little out pockets like this in the bowel. Okay. Literally ballooning of the bowel. Anybody want to take a stab of why that happens? It's due to low fiber in our Americanized diet. We don't see this in all the countries because other people eat better than we do. They eat their fruits and vegetables, okay? We do not. We live at McDonald's and Taco Bell, okay? So the diverticulum or diverticuli are the little pockets, okay? When it gets infected, it's called diverticulitis because poop gets stuck in there, and then if it sits and sits and sits, it can get infected. That puts you at risk for that bowel that's already stretched like a balloon to pop. Okay, if that pops, you get poop in your peritoneal cavity, you get a very major infection. Okay? So, if they're not currently infected, we need to tell them, dude, you need to eat more fiber. Okay? If they are infected, they need low fiber diet until the infection is better. Because fiber does make us gassy, right? We don't want to put extra stress on those little balloons because then they can pop. So low fiber diet when they're infected, high fiber diet to prevent it from getting worse, okay? Or to prevent making more of those, okay? Ileostomies, colostomies, okay? These, depending on where it's at, is where it gets its name. The ileum is going to be an ileostomy, okay? That is the small intestine right before it goes into the colon, okay? If it's a colostomy, it's in the colon somewhere, okay? All right, so if it's semi-liquid, it's probably more over here in the small or the large intestine. You guys understand that? If it's pretty solid, it's probably more over here, okay? And that's usually from colon cancer, from Crohn's disease, or ulcerative colitis. So the younger people that have them is usually from the autoimmune disease of Crohn's or ulcerative colitis, okay? All right. Do you guys know what that looks like? Have you guys ever seen that? An ileostomy or a colostomy?
My mom used to have a colonoscopy.
So you've seen one? Yes, no?
Yeah.
I'm typing on the wrong thing. So you learn how to change the bags and all of that stuff in nursing school, okay? And we call the little spot that comes to the skin, we call it a stoma, okay? This is kind of telling you where they can occur, okay? Okay? And that's what it kind of looks like. They literally take the intestine and bring it up through the skin and make a little opening outside of the skin, a surgical opening, okay? Then they have to take their bag on and they have to change it daily, okay? That's what it looks like. It's kind of fleshy, red fleshy looking. We want it to be pink and moist. We don't want it to be purple or gray, because then that means it's probably not having enough blood supply, okay? Okay, liver disorders. Biggest thing you need to know, who's at risk for liver disorders?
People have like, not
Heavy alcohol.
Alcoholics. Yep. Or people who have experienced hepatitis C from tattoos or from drug use. Okay, hepatitis C affects the liver. Also, the newer thing now, because we have so much diabetes in America, is non-alcoholic fatty liver disease. Pretty much your fat. And it starts to deposit fat into your liver, and you have fatty liver disease. Okay, and it makes it become cirrhotic as well. Okay, it's really hard to tell somebody their liver's failing because they're fat. So, all right, so cirrhosis, you do need to know that it's irreversible liver disease. When we get to this stage, that liver is done. A liver from anatomy class should be nice, pink, and moist. When you get to cirrhosis, it's brown, yellow, with all the fat. It's not looking nice anymore, okay? Twice as likely to die of cardiac disease than liver failure, because the liver also makes you get swollen, fluid. The liver also controls blood clotting, so these people can bleed out, okay? The liver is definitely an important organ, okay, guys? So when we start to mess with that, it's looking pretty morbid. Hepatitis, again, you can have acute hepatitis. Everybody in this room could get hepatitis from the cafeteria. Hopefully that never happens, but that's going to be A and E, okay? So hepatitis A and E, okay? Think you eat it and it comes out your ass, okay? So A and E is self-limiting. What does that mean?
It's self-limiting.
Self-limiting.
You're controlling how much you're taking.
It's going to take care of itself. You're going to be sick with vomiting and diarrhea for a couple days, but you guys are all going to live, and you're not going to have it forever. It goes away, okay? The virus goes away. B and C, you get from sex, tattoos, things like that. That stays with you. You cannot treat it, and it does not go away, okay? So A and E is the food you eat and out your ass, so think about it like that, okay, because it causes diarrhea. A and E, B, C, and there is a D, but you can only have D if you have B, so don't worry about that. But B and C you get from tattoos and sex, okay? So those can also cause severe hepatitis, which can cause liver failure, which is cirrhosis, okay? These patients, they do need protein, but they do have to, let's see what it says on here. Because too much protein can also make them swell. Definitely no alcohol, okay? They can have ascites, which is where their stomach gets super swollen, okay? So hepatic encephalopathy is the worst case scenario that can happen for somebody with liver failure. It's because the liver also processes ammonia, and ammonia builds up in your bloodstream and makes you kind of crazy, okay? You'll learn about that more in nursing school. And pancreatitis, alcoholics as well. Middle, severe pain with vomiting, okay? Clear liquid diet during pancreatitis episodes. Gallbladder disease, right upper quadrant pain, it's right behind your liver, okay? Gallstones, okay? Female fat and 40, those are risk factors for having gallstones and gallbladder disease, okay? So female fat and 40, okay? At least I'm not fat. All right, and so cholecystectomy is having your gallbladder removed. So then you need pancreatic or enzymes, other enzymes to help break down your food. So that was all of that very quickly, okay? So make sure you review it.